Welcome, everybody. Welcome to another episode of PEM Rules. I'm your host, Yaron Ivan, as usual. And today we have a very special episode with a very special guest. Today I'm going to talk to Fatima Levent, one of our pediatric infectious disease doctor who I love to consult. Wonderful physician, wonderful colleague. And I invited her on the show a few weeks ago, and she was more than happy to join and have a great discussion about fever, which is a very, very popular topic in the pediatric emergency department. Thank you so much, Fatima, for coming on the show with me today. Great pleasure to have
Thank you.
So let me just introduce you, Fatima, to the people who are listening to the show. And you're going to help me. You're going to have to help me a little bit.
Of course.
Fatima, you went to med school in Turkey.
Yes.
Help me with the name of the university, because I'm
So
probably going to mispronounce it.
It's Çukurova University.
Çukurova University, and that's med school.
It is my med school, yes.
Right. So in Turkey, correct me if I'm wrong, you don't have to go to undergrad to go to med school. Is that right?
That's correct. So you go directly from high school, yes.
And then you completed your residency in pediatrics at Texas Tech University, Health Sciences.
Yes.
And smart move, went to a fellowship in infectious diseases at Baylor College of Medicine, aka Texas Children's. Is that right?
Yes, that's correct.
Which is an amazing, amazing children's hospital. So clearly you got some excellent education. You have special interest in neonatal infections, GBS, antimicrobial stewardship, which I know you're very involved in our hospital, infection prevention and control. And I can tell you guys, beyond all that, Fatima is one of our favorite consultants to call because she's always super available and super willing to help. When I do consult her, which is not very often, we often have some very interesting discussions that I think the residents really benefit from. So welcome, Fatima. Thank you very, very much for doing this. I really appreciate it.
Thank you so much for having me. I'm very excited that we're going to talk. And we always talk about patients, but this is a great platform to discuss a couple of the common things that we see and also share it with others too. So I really appreciate you having me.
Thank you. Thank you very much. And thanks again for coming. And here's what I want to, here's what I want to start with. And see, this seems to me always very, very odd. So I would say by far, the most common presentation I see, the most common presentations to the pediatric emergency department are infectious related. Yet I find to consult pediatric infectious disease the least. I consult neurology and orthopedics, for example, a lot more often. And I think it's because this notion that really most fever, which is probably the most fevers, which are, fever being the most common reason for a child to present to the pediatric emergency department, or at least one of the most common. I must say, in my experience as a PEM fellowship, as an attending for the last, 5 years, I feel that I find that true bacterial infections are really hard to come by. In my personal experience, I've diagnosed a child with true bacterial meningitis once. It was a 3-year-old with pneumococcus. I learned it was pneumococcus a day or two later. I think I did an LP with a full septic workup on a newborn and find GBS maybe twice. And very infrequently, I find true pneumonias. Most of the time, if I get an x-ray, is to kind of try to put the mom at ease. And the x-ray is always viral, or at most it says atelectasis versus pneumonia. I don't think, very few times I've actually found lobar pneumonia. And I can't remember the last time I got a true positive blood culture on a kid that was truly bacteremic. I do diagnose UTI fairly frequently, although I do feel that we probably overdiagnose it. I get a lot of UAs that look bad. 2 days later, the urine culture comes back fine, and I have to call the parents to stop the antibiotics. So that happens a lot. And it is just my sense that bacterial infections are very uncommon in healthy, vaccinated kids. What's your opinion about that?
And you actually did a great job of explaining common presentations to the ED, and fever is definitely one of them. And it worries parents a lot. It makes the child uncomfortable. So that's why they usually end up in the ER for being evaluated because they're scared. They don't want to miss anything. So as you mentioned, we are seeing a lot more viral infections with this presentation than bacterial infections. And one of the reasons for this is we have been doing a great job on vaccinations. So we started giving PCV13 in 2010, which is the pneumococcal vaccine, the 13 valent. And with that, our invasive pneumococcal disease has really gone down quite a bit. And when I talk about pneumococcal infections, strep pneumoniae is the most common bacteria that causes ear infections, sinus infections, lung infections. So whenever you see those coming down, and of course the invasive infections like bacteremia and meningitis are much less common than even before. So when you have a fully vaccinated child, so the more likely reason that they come to the ER is they have picked up a virus, they had an exposure of some sort, and they come and get evaluated. So now, though, we have been seeing some of these patients who have immunodeficiency or some other chronic diseases come to the ER and they are found to have strep pneumococcus bacteremia. So they have to be evaluated for further for their immune system. But most of the time, the patients that you're going to see are not going to have any of this. And because we have been vaccinating, we are getting rid of some of the multi-drug resistant organisms, and we're having more sensitivity to even antibiotics like amoxicillin, especially for like ear infections, sinus infections. So definitely vaccination has made a big difference.
And do you agree with the notion that I teach the residents, hopefully I teach them the right thing, and I think the AP supports it, that when you find an ear infection in a vaccinated patient over 6 months of age, and I don't want to go through the whole guidelines, but watchful waiting is almost always a very reasonable approach. Is that right? And again, that to me, that's because of pneumococcus conjugate vaccine.
Yes, that's definitely correct. And you have actually pointed out a very important thing right now. If you are comfortable and the parents are comfortable, 80% of the ear infections are going to get better.
80.
However, yeah, so that's pretty good. And then just to treat, if they're not getting better, then you might need to treat them. So if you watch them and in a couple of days they're getting better, you don't have to do anything. And that way you're avoiding unnecessary antibiotics, because as you start the antibiotics, if the patient gets better in a couple of days, you don't know if the antibiotics made the difference or if they were going to get better anyways.
Right. And what do you say about UTI? Like I said, I do find UTI every once in a while, but my sense is that also is overdiagnosed.
I totally agree with that. And that's another big topic that we can talk for a long time about it. But I agree with you that we're probably overdiagnosing the urinary tract infections. First of all, our urinary tract infection diagnosis depends on how you obtained your urine culture.
Sure.
And depending on the age, you might go for an obtained sterile, obtained just clean catch urine versus a catheterized urine on younger kids. And like if you are putting a bag urine and culturing it on a little neonate, sometimes that might be positive because it's not clean. So, and then the other thing is evaluating the urine analysis with the culture. You can have asymptomatic bacteriuria, and you might be having a virus or some other, underlying disorder. We see a lot of Kawasaki cases, for example, and they might have sterile pyuria, and the culture doesn't grow, or the culture can grow and you might not have any pyuria. So I feel like you have to evaluate the patient, go with the recommended guidelines, and evaluate and then diagnose it. But you have to be careful. And I understand, when the patient comes to the ER, you have short period of time, worried parents, and sometimes you don't have all the data like the culture results. So you might need to just start treatment and treat them appropriately.
Very good. Yeah, no, I think I try. It's always a little bit of a somewhat of a battle, but I always try to explain to the parents that if your child is in diaper, I need a very reliable urine sample, and unfortunately, that has to be done only with the catheterized sample. And I tell them I want to try and treat your child appropriately. I don't want to condemn them for 10 days of antibiotics if they don't truly need
Mhm.
it. So, and my nurses are
Mhm.
excellent. They cath kids in 2 minutes, and it's all good.
That's great. That's actually important to do it appropriately. But also the other thing that I see sometimes is we do a UA and some ERs don't reflex it to a culture on a younger patient,
Hmm.
and the UA looks abnormal. Then you sometimes go ahead and do the treatment, but the culture may not grow,
Hmm.
if you have sent it. And so you have to be careful of how you're ordering the UA and make sure that you are getting a culture if you're ordering a catheterized urine.
Sure, sure. Very good. So let's move on, Fatima. I also wanted to talk
Sure.
to you about one of the other things, as a pediatric emergency doctor that I find all the time, like you
Mhm.
mentioned, is like how fever really scares the parents. And it's really,
Mhm.
I've been doing this for over 8 years now, and it's really incredible to me how still fever really scares parents. And some parents treat the fever around the clock. I had a patient yesterday. She
Mhm.
woke up her child from sleep every 4 hours so she can give the Tylenol. I'm not kidding. Um, no, it's true. And my learning back when I took microbiology as a biotechnology student, as a resident, is that always been that fever is normal, beneficial. It's part of the innate immune response, and there's nothing dangerous about it. And I've also heard of few studies. Tell me what you heard. I'd like to know what you heard. That kids with
Mhm.
viral illness who get antipyretic around the clock are often sick for longer because here they are mounting an immune response, and we take it away. Now, I certainly encourage the parents to take the fever away if the child is uncomfortable with the fever, especially if they
Mhm.
don't drinking. I don't want them dehydrated. But I generally encourage leaving the fever be if the child is comfortable with it. What are your thoughts about that?
I totally agree. We are definitely aggressively treating it, and as you mentioned, from the time that we were being trained to now, I think we have learned quite a bit. A lot of studies show that you don't necessarily have to treat the fever. It is your body's response to infection. Your immune system is working. And some infectious disease specialists would say, celebrate your immunity and celebrate the fever, which, I know it's
I'm
it's
totally
very
going to use that.
scary.
I'm totally going to use that. Totally.
Yeah, so it's really your body's response, and as you mentioned, you don't want to suppress it too much. And there are some smaller studies, it's not a placebo-controlled study, so I can't really totally tell you that this is real,
Sure.
but you don't want to use it unnecessarily, and it doesn't come without side effects. If you use a lot of Tylenol, your
Yes.
liver enzymes go up. If you use your ibuprofen a lot, your kidneys might get affected,
Hmm.
especially if you're vomiting and not drinking very well. You're already dehydrated, so you have to be careful of using, all these antipyretic medicines. And as you mentioned, I think it's now recommended not to use antipyretics unless the patient is uncomfortable.
Sure. Okay, good. I'm glad to know I'm teaching the residents appropriate
Mm-hmm.
things. Now, do you agree also with the notion that as a pediatric infectious disease, I've always learned that the number that the parents see on the thermometer is pretty meaningless. In other words, a 7 months old can get 104 from every little benign rhinovirus. And I tell that to the parents. I can't remember the last time I got a fever. I got a fever, I think, last time in residency when I had strep throat. But adults don't seem to get fever very easily, whereas kids, especially newborns and babies, get very high fever from every little viral illness. Do you agree with that?
So it is possible, and it doesn't always happen, but it is possible that as young kids, as their body getting exposed to different types of viruses, their body doesn't know what to do, and then they just over exaggerate the response. And
Hmm.
that's why you see the fevers, because your inflammation is there as well. Your body's working to get rid of it. And as you get older, you don't really respond the same way that you responded previously. Your body gets exposed a lot, and it knows how to behave basically. And as you get older, you see much less of these higher fevers, but it can happen anytime depending on the culprit. So whatever is causing the fever can also play a role, as well as the host, which is our babies and kids.
Sure, sure. Do you agree? Is there a number that when someone like me consults you that makes you more concerned the child has an SBI as opposed to a viral illness, meaning above 104 means bad or something like that?
I usually don't look at the numbers as much other than the clinical presentation. So
Okay.
that's why we do the whole, history and physical. So I always try to tell our residents and students, go to basics. So other than just one number, how's the patient looking? Is the
Hmm.
patient ill appearing or well appearing? That's to me, that's more important than just one number on the fever. However, if the patient is having 103, 104, 105s, and not doing well and just lethargic and not feeling well, definitely it's a little bit more concerning than 101s and 102s. So I would recommend to look at the whole presentation and then decide what to do.
Okay. So, moving on, when our residents come to the pediatric emergency department, one of the things I try to teach them is to be as conservative as possible with testing.
Mm-hmm.
So, you know, in United States 2021, we can do a lot of things.
Sure.
And I can do a full workup on any patient with fever. As
Mm-hmm.
CBC, for example, comes to mind. And
Mm-hmm.
I personally generally think of a CBC as a fairly useless test because it doesn't tell me, and you correct me if I'm wrong, it doesn't tell me if it's bacterial or viral. It certainly doesn't tell me where the infection is. I personally encourage the residents to get me a urine analysis. Urine analysis tells me UTI, no UTI. That translates to antibiotics, no antibiotics. As we discussed, UTI is the most common SBI in newborns. So I try to be very conservative with my testing. Do you agree with that? Are you aware of any threshold that a CBC or a CRP or an ESR alerts you that this is maybe a bacterial infection? We should dig further.
So you actually, you are definitely right on target on evaluating for tests. So there's a notion called diagnostic stewardship. So other than antibiotic stewardship, diagnostic stewardship tells you not to order tests that you don't want to know the results for. So, and don't order too many even blood cultures unless you want to see the results, including CBC, CRP, SED rates. However, I feel like depending on the presentation of the patient, if a patient, for example, has been having a fever for more than 5 days, a CBC, a SED rate, a CRP might be very helpful to evaluate for Kawasaki. We have seen a lot of patients who has MISC, for example, in the COVID world, and you have to do even more testing to evaluate for the syndrome. And
Sure.
these are a little bit harder, but for somebody who's presenting with 1 day of fever and the patient is well appearing, still eating well, but maybe just had a little bit of vomiting and needs hydration, and was a little dehydrated, you may not necessarily do anything. However, if the symptoms have been ongoing for a little bit longer, CBC might tell you a little bit more intense. So white blood cell count might not be very high, but I usually look at the differential. So if you have lymphopenia, for example, that really leads you more to the viral infection versus neutrophils being really high, like 80-90% might be leading you more to bacterial. And especially if you have bands in addition to that and you have really high neutrophils, that might be something you might be concerned about. And then the other thing is the platelets. They're acute phase reactants. They might be slightly elevated on just regular viral infections, but if they're very elevated, again, you need to dig a little bit further. And if you have a patient who has allergies, for example, eosinophilia might be even there, or somebody with parasitic infections that can just show you, I highly recommend that you look at the differential of the white count. And of course, anemias and thrombocytopenia or thrombocytosis might lead you one way or the other. For example, if you have a mono infection or an acute CMV infection, you can have some of the bone marrow suppressions. And again, bone marrow suppression could be with any other viral illness. So if somebody is presenting with a little bit longer fever and other symptoms, so you can just adjust your treatment and plan and the testing. So if you have somebody with, let's say you're concerned of deeper infections, osteomyelitis,
Hmm.
bacteremia, pneumonia, or any other like more serious infections, procalcitonin would be a good help to decide between CRP. Like CRP is a little bit non-specific. So for bacterial infections, you'll see higher procalcitonin levels, and it will be higher even earlier than the CRP. So I think if you're considering someone, let's say you're considering viral meningitis versus bacterial meningitis, then you can do a procalcitonin to kind of lead you one way or the other.
Okay. And what I hear you saying is that the differential a few days out does have some values as opposed to at the day of.
Right. And it might be actually even on the day of as well. But if you have a patient that really doesn't need labs, then you don't have to do it. I feel like that's why I totally agree with your recommendation of like, if you really don't need it, don't order it. Because that one day of fever, you might see a bone marrow suppression, but it might get better later on. So like that wouldn't change your approach. But if the patient has been sick for a while, then you might want to know a CMP, for example. Do we have liver enzyme issues? Do we have kidney function problems? So, if they're only in the ER and you're just given a fluid bolus and they're doing great, you don't necessarily have to go deeper. But, of course, there are some other situations like parents are very worried and, you have to reassure them. And of course, that's a good time to do a little bit further testing.
Yes, I can't tell you how many patients in my ER they want to see blood tests. Parents love. Some
Right?
parents really love blood tests, and I always teach the resident a blood test is a very small price to pay to reassure a mom. That's one of my rules. Worried parents don't go home. If mom needs a CBC to be reassured, let's go. If I see a
Right.
child with URI and mom is convinced the runny nose is pneumonia, let's get an X-ray. No big
Hmm.
deal. But I do tell the parents in my personal approach is I don't do CT to reassure a parent because I don't feel that's fair for the child, and I don't
Exactly.
give antibiotics to reassure a parent for the same reason.
And that's great. And actually, like talking about diagnostic stewardship, we have to be stewards of antibiotics too. So, unless we really need to, you shouldn't use antibiotics because we are seeing multi drug resistant organisms causing multiple types of infections, starting with urinary tract infections, skin infections, and pneumonia. So, definitely, we need to be watching that very closely.
Hmm. Fatima, one last question that I was asked by one of the residents or med students just too long ago, and I hate saying to the residents or to the med students, I don't know. I hate saying that. So they asked. We were talking about bacterial infections, and we were talking about how common viral illnesses are. And I asked the resident what is the most common SBI because we had a newborn we were going to do a workup on, and he very very nicely said it's a UTI, and I said, that's true. That's actually true later in life also because we don't have a vaccine for it. Why don't we have a vaccine for E. coli? Is anybody working on that?
That's a great question. So I want to have vaccines for every different bacteria and virus, but I would tell you, so I would start with a different approach. So for neonates, we see a lot of GBS, Group B streptococcus,
Right.
which is a very common cause of early onset sepsis, and it's still a significant cause for late onset sepsis as well. And I can tell you that they are working on a GBS vaccine, which is in phase 3 trials. And my mentors actually were working on that. So I've been getting updates on them. So what they're planning on is to give the vaccine to the mother so mother can give the antibodies to the baby so they can be protected. And I am sure in the future we'll probably have an E. coli vaccine. It's just, creating a vaccine is a little bit tougher and harder on different mechanisms. It comes to public health and it is expensive and like it has to make sense to use it, and it's hard to just kind of get it through, and there are some higher priorities than E. coli at this point, but I'm sure in the future we might have some, and I'm not aware, but I'm sure some people are working already on some of the vaccines because now that GBS is less with the early onset because of the intrapartum prophylaxis. E. coli is being seen a little bit more, especially on premature babies.
Very nice. I think one of my colleagues just had a baby, a newborn in the ER with sepsis, and it turned out to be E. coli bacteremia, which is,
Okay.
pretty
Yeah,
unusual.
we are seeing it right now. I
Yeah,
can
just
tell
a few
you
weeks ago. Yeah.
in service right now, we have 2 babies who had E. coli bacteremia, and one of them had meningitis too.
Do they have galactosemia? Isn't that a board question? I'm so
That's
sorry.
actually a board question. You always check for that. So our newborn screen should be checking for it.
Right. If you get a E. coli bacteremia, you got to check the baby for galactosemia. I remember that from the Peds boards.
Yes.
Well, Fatima, thank you so much for giving me your time this afternoon. I really, really appreciate it. And again, thanks again for being such a great doc and being such a great teacher for our residents. I know all of our residents love the infectious disease rotation, obviously because of your good education and your colleagues over there. I appreciate your time, appreciate your answers, and hopefully we get to do some other episode in the future.
Thank you so much for having me. I really enjoyed it. And, you guys are a great team. My team here in infectious disease are ready anytime you need us. But, this is amazing to work together and teach our residents and students.
Agree with every word. Thanks again, Fatima. Thank you very much.
Thank you.
And there you have it, guys. Thank you very much for listening. I appreciate it. Please don't forget to check out pemrules.com. Submit any feedback, suggestions, any topics you want to hear in the future. I hope you like Nirvana. This is one of my favorite songs to play on the bass. As you can probably imagine, I grew up in the 90s. Bye, guys. Have a great day.